COVID-19 series. So I hope you're comfortable wherever you are, and thank you for joining us and spending your late afternoon, early evening with us. We've got a really important subject here. We're going to be talking about health inequalities around COVID-19, and I just want to give a big applause to Imperial College team at the background, just making us all feel comfortable and getting us all on the same page. And so before I start, who am I? I'm Janet Wildman. I've been working with the public sector and communities for over 25 years on a range of different change agendas. But what brings me here is my real research interest as a freelancer in social movements and in health and care. And how do we bring the passion from grassroots individuals, communities, organisations into systems and really achieve transformational change? It's a wide agenda, but we've been working on this for over 3 years, and I've been working with Samira Ben Omar, who's going to introduce herself in a moment, around community voices, and we're going to tap into that as we go through the evening today. But before I do that, there's some housekeeping that we just need to just to let you know about. So for the first thing is we're going to spend a lot of time trying to answer your questions. So if you've got questions, please note them down and then post them in the YouTube comments. So there's a section in the YouTube where you can actually start to put your questions together and start to post them. We've already got around 8 or 9 questions, but if there's any burning questions that might come up as a result of the talk today, then please post them up and we'll try our best to answer them. So that's a couple of housekeeping things. So the other thing is just to be respectful of other people when asking your questions. We might not be able to answer all the questions, but that doesn't mean to say that we won't try. So we want to have an open discussion, and your involvement is absolutely critical on the subjects of health inequalities, and let's talk about COVID-19. It affects us all. This is a very personal subject. It affects us all in so many different ways. So, you know, don't speak up, let your voice be heard. We're very interested in the conversation. We're very interested in how this agenda affects you, and also what actions you're prepared to take as a result. So yes, let's have the conversation, but let's ground it in some reality around what is it that we're prepared to do as a result. So less about me and more around the people who you've tuned in to come and listen to. So we've got Meerat, who's going to be introducing herself first, and then we're going to hand over to Samira. So they're fantastic. Before they introduce themselves, I've been working with them for Samira for 3 years and Meerat more recently. I really enjoy the challenge that they offer, and you'll hear their personal contributions to this important subject. So first of all, over to Meerat, just to tell us a little bit about your interest in this subject. What brings you to this space today? Over to you, Meerat.
Thanks, Janet. So I've also worked with communities internationally and more locally for the last 15 years. And I'm here today as part of my role with the National Institute of Health Research Applied Research Collaboration for Northwest London. So this is an organisation hosted by Chelsea and Westminster Foundation Trust, and it's also led by Prof Azim Majid at Imperial College, so which is why this is part of this Q&A at Imperial College. And generally as a programme, because we're in the Department of Public Health at Imperial College, we are and have been really interested in how we tackle health inequalities more generally. And then when COVID happened, it kind of gave us an opportune insight into a case study of things that were happening, which could really help us understand one, what's going on with our local communities and what they're doing, but also what are they doing to tackle health inequalities themselves. So that's where my interest into this all came from.
Thank you, Meerat. That's really fantastic. Meerat has a wide breadth of experience and skills that we all learn from when we speak with her. So thank you so much, Meerat. Over to you, Samira.
Hi. Thanks, Janet, and great to be on the panel with you, Meerat. My name is Samira. I've worked in Northwest London, I suppose, for over 20 years while working in other places in London and across the country. My background is in community development, really to working with communities in areas of huge health inequalities. I suppose that's my interest in this area of work, is how can we address the challenges that exist within communities, but in working with communities rather than outside those neighbourhoods. I'm currently working as Assistant Director for Equalities across the Northwest London collaboration of CCGs. That's the 8 CCGs across Northwest London, and they cover a population of 2.1 million at the last count.
Thank you so much, Samira, for that fantastic introduction to who you are, what you're doing in Northwest London, and the fantastic. She hasn't mentioned community, the work that she does in Community Champions, but again, if you know Samira's background, why don't you post that in the question in your YouTube question box, because she's done some fantastic work there, and I think she should definitely share a bit more about it. So just to get us on the same page, I wondered if we could just go and do a little bit of a poll. If you refer back to the YouTube, there's a little bit of a poll there that just helps us to get onto the same page and get us started to talk about health inequalities and how what that means in terms of the context of COVID-19. So there's 3 questions there, and I wondered if I know Maria's there in the YouTube platform, and I wondered if you could just basically have a look at that. And the 3 questions is what let's just go to the questions. Right, number A. Has your life been like during COVID-19? And there's some options there. Is it been easier, harder, the same? B, as a resident of wherever you live, how connected have you felt to your local community during the pandemic? More connected, less connected, or the same? So those are the questions that we have. And I wondered if you could just take some time to have a look at those questions and post up your comments. But while you're doing that, and I'll just prep Maria to come to let us know what's happening in YouTube. I just wanted to put those questions to our lovely Meerat and Samira. I mean, what's it been like for you guys during COVID-19? If you can unmute yourself and just tell us a little bit about what's it been like for you.
Shall I go ahead?
Yes, please, Samira.
So I think it's I suppose COVID is really interesting in terms of, has it been easier or has it been harder? It felt different. So I've personally been affected by COVID. My brother was in hospital for quite some time. He was quite unwell for a few weeks. So it really doesn't hit you until it really hits you. And then you begin to realize actually the impact of on the fact that this is a real thing. What's really interesting is you're working in a healthcare settings where you think you have enough information, enough data on how to deal with the system. But it's a completely different thing, being at the receiving end of it. And my brother was one of those who didn't want to go into hospital. He said, I would rather die at home than go into hospital. So it's really interesting when we had the feedback through community voices to hear that very same thing. What is going on? To what extent? Do you have somebody who is in the family that you work closely with, and you'd assume that actually they have enough confidence in the healthcare system to enable them to seek help? It's hard working from home. It's a real challenge, both in terms of your mental health and well-being, just being able to, it's very different connecting face-to-face versus virtually. There's something about that. And also the work is relentless, and there is a sense of urgency. So while it's quite exciting doing the work of COVID and the impact on BAME communities, it is quite relentless because we're all aware of the issue of being that we have a small window to make a change. So I'll just stop there.
Thank you. Meerat, what about yourself?
I'm reminded of the Alan Sugar quote when he said, who's died? I've not died. Nobody I know's died. And I think that for me sums up COVID. So you have people and communities who are doing great, who are baking sourdough and going to the park and spending time with their kids. And then you've got groups of people who have gone to multiple funerals and are planning multiple funerals because actually they're in high risk categories, or because they live in accommodation where if somebody gets COVID, everybody gets COVID. And so I feel that I feel like I'm in the middle of the two spaces, because we have had funerals and we have been planning funerals, but we've also been, the baking sourdough type of family as well. So I feel and that's where it all becomes a bit complex, doesn't it, in terms of, is it harder? I'm not sure.
Okay, so just over to Maria. What are people saying in YouTube about how they've been coping with COVID-19? Could you unmute yourself and share with us? Okay. Well, while Maria's posted up. So she says the results are available. Let's see where the results are. Okay. While we get the results, I wondered if we could.
It says 50% harder, 15% easier, 10% the same.
Oh, that's interesting. Now, how does that resonate with us? I mean, in terms of our experience of COVID-19, do we feel like it was really incredibly hard, given 50% is quite a huge number of people feeling that does resonate with what we've been hearing in community voices, isn't it? What do you think, Samira?
So absolutely, and without a doubt, I think there's a real issue about how difficult it is, especially if you're living or working in an area where there are huge fatalities or people, a huge number disproportionately impacted. Certainly what we've heard for people, especially living in areas in Brent, where you have in 2 estates, you have multiple deaths, not one, not two, but multiple deaths. So you have your next door neighbor, your cousin, your uncle, your grandfather, all of those actually kind of been affected. So it slightly feels a bit like, if you're in that situation, it feels like the end of the world in a way, because you are in that situation and you don't know who to trust. The anxiety is really high, and understandably it's high. I mean, what hasn't helped for us is just getting the feedback through the WhatsApp messages. So you have your the COVID and the impact of COVID on BAME communities, but then and how you can access information and that you should seek help, advice and support. But then parallel to that, you have all the WhatsApp groups who are sending messages saying, don't go to hospital, they're not going to respect your cultural views and values. If you go to hospital, you would not be able to access ventilation that's given to people who are seen as having, white communities are seen as having higher priority and are prioritized over BAME communities. You have frontline staff, we've heard lots of stories, frontline staff who are saying they were not given appropriate PPE. Because they could not, they were not seen as really important. They were bank staff. They were not trained on how effectively to use PPE. So I think it's harder but it's harder on the individual within their family and community, but it's also harder if you're working in an environment that has all of those issues going on, and then going home and living with a multi-generational household with people in overcrowded accommodation, where you have others who are also frontline workers, whether they're supermarket workers or bus drivers. And then, so you have all of those tensions, all of those issues. How do you manage that? How do you deal with that in an environment where it's telling you that actually don't worry if you, only if you use PPE, or if you, use face coverings to go to work, or so I think there's a lot about unpicking what hard means, or what harder means.
Yeah, that's absolutely the case. And Meerat, before I'm just aware that we need to slightly move on. Meerat, I wondered if you could answer I'm just going through some of the questions that our audience has put to us. And one of the questions is, how do we get BAMI advocates on every board to champion all equality groups? This is from Nicola, but what's your sense around that?
I think we first need to get them on every board. We still have situations where they're not on every board, and then also it goes back to this. The problem with the term BAME is that we group people together. So people like me will be asked, or people like me will be on the board and tick the box, but then we won't have people like say you, Janet, there, or so we'll have particular communities missing. And so I think before even getting them, before even asking the question about actually how can they work with other communities, I think we need to start really thinking about who are the communities that we need to work with, who are the primary community that we need to work with, and what is that based on. So if we look, for example, at the health inequalities of Black communities and Bangladeshi communities, these two communities, the health inequalities have worsened for them, the situation's worsened for them. Black women are even more likely now to die during childbirth. We've not addressed that, and that gives us a real clear direction of who we should be working with, who we need to ensure whose experiences we're hearing and whose voices are and who is at the table. So I think instead of perhaps looking at BAME communities as a generic group, we need to start breaking it down and hearing from specific groups first.
That's so interesting. And Samira, do you want to come in on that?
Yeah, so I probably am gonna challenge back a little bit. I think, do we need to have a BAME advocate in every board? If our boards are inclusive enough, we don't need to ask that question. The problem with how sustainable is it to ensure that every board has a BAME advocate? How sustainable is that? Because it doesn't address the structural issues, the systems issues that actually got us to where we are. I think there's something about unpicking and unlearning and really reflecting on how did we get here, and then moving forward to something that's more inclusive, that really is reflective of the diversity of our population. I really think, because we've had it, and I've worked on the equality agenda for more than 20 years, where you have an equality champion on your board, or you have a senior champion. The issue is that none of these are sustainable if the infrastructure within our system and within our organization is just not fit for purpose. And to be honest, I would probably just stop very, very short of saying, I won't stop in saying there's absolute structural racism that exists within our system, so you can't address it by having BAME advocates. But I would stop just as very, very short of saying there's absolute systemic institutionalized racism that exists across the system. We need to have those uncomfortable conversations. Unless we do that, we're not going to address the issue by having BAME advocates on our boards.
And my own experience is that when you do have representative, whether you would call it token or they've hit the right box, they've ticked the right box, they're not supportive, they don't stay, they feel undermined, they feel like their voices are not being taken seriously. We need to ask a deeper question. And I feel like what you said, Meerat and Samira, is helping us to really think through what it is that we're trying to get to when we talk about representation. having people represent. I mean, who are they representing? What kind of voice do they have, etc. So I want to move us on to another really interesting question that our audience has put to us today. BAMI individuals being at high risk is receiving a lot of media attention. The BAMI community are also being misunderstood as the quote-unquote spreaders of COVID. What can be done to avoid such misconceptions? I'm going to hand this one over to you, Samira, before Meerat comes in.
So I'll probably answer this from a personal perspective. It was really interesting, I think, when my own brother recovered from COVID. And one of the things 2 weeks later, in asking him, so how are you feeling? And now you don't know if you're going to have COVID again. We don't know once you've had it. And his response was, but I didn't have COVID. I had pneumonia. And I said, well, no, pneumonia was the result of COVID. And it was, I don't want to tell people that I've had it because there's already a stigma that's been developed as a result of that. So in highlighting the issues around the disproportionate impact on BAME communities in relation to COVID, what we have done inadvertently actually kind of made people really anxious and really scared about declaring the fact that they've had COVID, rather than actually saying we've had it and we survived it. So there's something about communicating the issue and really beginning to unpick why is that. And it kind of, to me, there's a little bit of it. It feels slightly that we're heading towards this thing of almost the stigma that we've attached to HIV. Where people wouldn't declare their HIV status. And there isn't, and this is not based on any evidence, but there's some reflections of why doesn't that apply to cancer? Why does it apply to COVID? Why does it apply to HIV, where there is a disproportionate impact on BAME communities? So I don't know what's going on there, and I can't say that actually there's some sort of inherent way that either us as BAME communities are responding to these pandemics, or is there something wider in society that's actually kind of forcing or taking us along that route?
Okay, over to you, Meerat.
So I think for me, it's a case of having more accurate data and more localized level data, and for that to be accessible by people, not just presented through the media, but for us as citizens to access that. So globally, there is examples in Singapore, for example, of citizens who created their own apps in order to understand where COVID cases were happening, and one as a preventative measure in terms of understanding where to avoid, but also really to understand actually, what is going on in their own country. And so there are really good examples which it'd be great to adopt more locally in the UK, if not across Northwest London.
Thank you both for that. I had an incident where I was on the train just when COVID broke out, and there was a Chinese gentleman sitting beside me, who came onto the train, and a white colleague who was sitting down, and the Chinese person came and sat beside it, and she was in a fluff. She just literally just got up and she was like, please, almost saying, don't sit next to me, okay, because you're a carrier. And it gave that very clear sense on the train. So we really do need to think about how people become stigmatized and how we also absorb some of that fear as part of the BAMI community, and how that affects our choices in terms of accessing help. So thank you so much for sharing your perspectives on that. I've got another question here. The very vulnerable list of shielding did not include conditions affecting Black people. Do you have any views on how the list could have been developed to be more inclusive? So first, over to you, Meerat.
So we have been asked this question in various ways over the years, and I think that in itself is telling. It's not just about why the shielding list didn't include those, it's why we're not exploring these situations further, it's why we don't understand these experiences and these conditions more, it's why our outcomes still bad for particular communities, and it does sound like it is basically based on the systemic racism that currently exists and shapes what we do and how we do it. So we don't really work with our communities in the right way. We don't hear from them, and we engage them really late, and it's often on our terms, which means we miss a whole scope of areas such as these conditions, and not knowing that they even existed, and not really understanding they should be on the shielding list. So yeah.
Can I just come back to you on something before I hand over to Samira? We know that sometimes some conditions are just seen as conditions just for the Black community, and that has its own repercussions in terms of how much research is invested in that, how much money is invested in that, and whether or not it's actually true. What's your take on some of that?
So Angela Serni's done really good work on this in her book Superior, and she speaks of conditions such as sickle cell, where we in the West think it's a Black condition, and it has been underfunded in terms of research, and we've really not advanced our knowledge on sickle cell in terms of the experiences that people have when they're dealing with crisis situations and have to go into hospital, but also just generally the outcomes of these people with sickle cell. And then she's looked globally, and she said, actually, when you look globally at the statistics, people are equally likely to get sickle cell. It doesn't matter what race. A white child is just as likely as a Black child to have sickle cell, and realizing this has led to a whole screening program of all children in the States, but that didn't happen until relatively recently. So it's this. So you're right in terms of there's a whole science or a whole approach in terms of how we see things that has been validated and justified by our use of data and our approaches, the methods and the research approaches that we use, which can't necessarily be justified when you really start to look at things in a lot more depth.
Before coming back on that, Samira, I just wanted to push us forward to answer this question. What advice would you give to Black people who are too frightened to speak out about their experience of racism and neglect in the NHS and healthcare services? This is right at the heart of the work that you do in Northwest London.
So I'm not sure about the advice, because I think there's real challenge. There's real challenge in terms of speaking up. You can speak up, but that doesn't mean, there is no guarantee that actually that's not going to impact on your career. It's not going to impact on your progression. It's not going to impact on what support you get, what training you will receive. There's a real issue around to what extent you're able to genuinely speak up. To what extent, I think one recent example where somebody was really quite concerned about, and it's not related to COVID, but a real experience where somebody felt that they've been really pushed and bullied and harassed within a particular team. And I think, and there was a mediation that was taking place, and the first thing that actually kind of came, so this was over a period of 18 months, where you actually kind of think, you know, what is, and this isn't unique. So it was kind of it wasn't in our own CCG, but it was in a particular community, in a trust. And the feedback from the particular individual was actually, well, the person who has been the perpetrator of this said that actually, well, people are just jumping on the bandwagon at the moment. So there is something about to what extent people then feel validated just because they're raising, or they have if you like, they have the space to raise these issues. Now they've been accused of jumping on the bandwagon. So I think there is a real issue about to what extent we can genuinely and openly speak up about race and racism within the NHS, especially in relation to frontline staff. I mean, the classic example, just actually looking at PPE, and I'm part of a Muslim women's WhatsApp group, and they're all clinicians and frontline staff. And the key issue was actually, you know, if you have PPE, you've got your FFP3 mask, what you need is the strings rather than the ones that loop around your ear. It's a lot easier to actually put. The challenge of getting one, to the extent that they started getting quite creative with, you know, kind of just if you tear the bottom and then you put it up. So simple things like that, where you think it's actually kind of just matter of fact, especially in an area where there is huge, you know, you're 4 times more likely to die from COVID if you're frontline staff from BAME communities. You think that there'll be more proactive, but I think it just kind of shows the reality of where we are more than anything else. I do want to say something about actually kind of the issue of, you know, long-term conditions and, you know, disproportionately affecting certain groups and communities, and especially in relation to sickle cell, because Meerat, you mentioned sickle cell. you know, for some rare genetic diseases, you know, it took sickle cell to be 15 times more prevalent for it to actually be to have the testing for all babies. So it took 15 times. So it just makes you think actually what is going on. And actually for some conditions, some rare conditions, the research funding that goes into sickle cell versus the research funding goes into some rare conditions where the proportion is minute, is actually 20 times more. So, you know, for a condition that's supposed to be perceived to be affecting BAME communities, why does it take 15? Why do you have to have 15 times the number of people for you to get a similar amount of research funding or actually kind of screening at birth? So I think there are, and this goes back to the whole issue of, you know, if you have a black advocate on a board, does that address these issues? It doesn't. Long-term conditions affect certain communities because of the conditions that they live in, and they're impacted by that. If you live in overcrowded accommodation, where, you know, if you live in Brent, where you have huge level of 6 times, 7 times more likely to live in social housing if you're from BAME communities, and you are in, you have a long-term condition and you're frontline staff, and somebody says you need to stop smoking. I mean, where do your priorities lie? And if you just stop smoking, then you'll be able to avoid all those issues. It's a kind of it's a bit of a red herring. So I think we do need to actually kind of reverse the question around, why do we keep continuing to look through the lens of our organisation when we're addressing either research or actually kind of looking at population prevalence or profile in relation to long-term conditions?
Thank you for that. And I've got another question that sort of links into this, is how do we involve different communities in vaccine research? And I want to take us to the point where we answer that, but we also answer something that gets come up in the community voices research, that people feel really fearful about getting involved in research, clinical research to do with COVID-19. And we need to talk about that. What's the fear behind that? Why don't people from BAME groups want to come forward and be part of a research register, for example? Right? Can you tell us a little bit about your feeling? What's come up with in your practice? Let's start with Meerat.
So yeah, from the community voices work, we have heard that communities are really fearful of hospitals, for example, because they fear unequal treatment, or they fear that actually there's still a lot of structural racism which impacts their treatment they receive. And so a lot of the community groups are saying to us, actually, look, we really need to start communicating better with our local communities. We really need to start building trust or rebuilding trust where it's been broken. And so instead of just jumping in to expect people to be part of our research and be and help us with our research, we really need to first just start conversing with them again and talking to them and understanding them and hearing them and listening to what they're saying. And then through that, we can start involving them and engaging them with the research, because I think they'll naturally be interested. But it's just this whole, their trust is so broken that we really need to mend the bridges first, and not just jump ahead. Thank you so much.
And to you, Samira.
So you'll know that we've lobbied really hard that actually that BAME communities and frontline staff in particular are provided with, you know, the vaccine as soon as that becomes available, and that they'll be prioritised. And it was so interesting, and you saw in the WhatsApp group the first thing that came was a petition to say don't do it because you're being used to as a test. So they're testing on you, don't use it. And it really gives you the sense of the how, as Meerat said, how much, to what extent trust is broken. So you lobby on one hand to actually kind of have that available, and then the first thing that comes, not how we actually raise awareness about the availability of it, so people proactively enable and empower themselves. And it's the same with the whole anti-vaccine movement, and to what extent that is highly prevalent in BAME communities, because the issue is that we have to address the fundamental mistrust of our public sector organizations and public sector systems. No amount of comms, no amount of leaflets, no amount of films in whatever languages that we have are ever going to address the anxieties unless we're honest about the fact that actually so far our communities have not been served in the way that they needed to be served. I mean, Sharon was very clear, you know, in one of the films where she said, we are aware we're underserved. If you are aware you're underserved in a population in Northwest London where you have 65% of the population are from BAME communities, and then you're saying that actually, you know, we need to communicate to you how we access services, it's almost talking across purposes.
Yeah. That's really, really interesting. And I've got another question. What strategies do advocate groups, academic groups have to amplify robust evidence on the race-specific COVID-19 research stroke public health initiatives to speak louder than misinformation stroke conspiracy theories? I want to wrap that up into the work that's going on in terms of the observatory around collecting. So it does feel like a lot of more evidence is out there in the public domain. So is this about giving us more evidence? Is this about trying to tackle the misinformation, or is there something else that's going on that we need to tap into? So I'm coming to you, Meerat, first, and then I'll hand over to you, Samira.
For me, it's not just about capturing more evidence or gathering more evidence. It's also about how we understand the production of knowledge and evidence, and how we accept the variety of knowledge evidence that exists, and that includes the evidence that exists from the community groups themselves, because they have an incredible amount of expertise and knowledge built up over decades. These are communities and organisations who often outlive us in the statutory and NHS provider sectors. We often leave a lot sooner than they do. So they've built up a lot of knowledge, an incredible amount of data, which is captured through the stories and the narratives and the relationships that they build, but also through the tangible examples that they have of things that work to tackle inequalities. It could be particular classes that they run, or it could be sessions that they run, or it could be a whole group of lots of different things that work for a family unit in order to help them overcome things such as access to education, or all those factors. So there is things out there, and it's about how do we start learning from a wider variety of knowledge and a wider variety of experiences that already exist, rather than trying to think that everything needs to be answered by more data and more numbers.
Can I make this more personal to you, Meerat? Because, you know, within Imperial, is there a more preference to a particular type of data collection, the type of data that you feel actually helps to inform decisions and inform your reports, than the sort of softer data that you're talking about that's lodged in communities, how communities live their lives, more qualitative data, if you like? So is there something going on there that we ought to get to the heart of?
Yeah, so Imperial is a science, technology, engineering and maths institute. I mean, that's what it specialises in, and it does it incredibly well. And then you do have, so yes, I agree, that is the dominant approach. You know, we do tend to look at numbers, we tend to look at those type of approaches, the natural sciences. But even within that, you have people such as Professor Helen Ward, who is pushing for and leading on qualitative research within the Institute, because we understand that it's really needed. We understand that it helps us understand the questions a lot easier. It helps us understand why, for example, we're not tackling health inequalities, or it helps us understand the experiences that we really don't understand through the numbers, which are so crucial to the numbers work as well. So you do have a growing number of people within the college who are working on qualitative research, but yeah, it is a challenge. Thank
you for that. And over to you, Samira. Any comments or observations or insights on this?
So I think I think the issue is that we, why is it so hard for BAME communities? If that's the question, why is it so hard for us to connect with BAME communities around research or around the wider work? The problem is to connect. To connect means that you need to build a relationship over time. Why should they trust you with their lives, their stories, with their perspective, with their neighborhoods? The only time we interact with communities is only one, is that we want to get your feedback, or two, when something goes horribly wrong. So the issue is that there isn't a relationship there. There's more of a transactional type of relationship that's based on, we want something from you, we'll take it from you. I mean, I've said it time and again, there's no such thing as hard to reach, there's easy to ignore. So if you want to invest in your community, then you invest. They're going to be there for generations to come, as Meerat said. They're not there for a short period of time and then move on to a better role, or like all of us, or to a different organisation. They've lived there for generations. They know what the issues are and they know what the solutions are. We just have to connect with them. But we can't do it in this piecemeal way where we go in, we ask them a question, they give us the feedback, and then we go away. It's disingenuous, and it's more of a performance rather than a real way of connecting with communities on what matters to them, not through our organisational lens.
That's when you say that, Samira, that's almost like flipping the script, right? A lot of programs are not designed, don't start with that, right? I mean, a lot of people are talking about their recovery plans, they're talking about their risk assessments, they're talking about the next equality impact assessment, and it's not from that lens. It's not from let's go in and let's have a different type of relationship with communities. This is about us and our page roles, our careers, our programs that keeps us in the roles that we currently are in, and it's self-sustaining. For a lot of people who have joined the call, who might be listening to this YouTube, that what you're saying is too high risk for them. They don't even know when to start the conversation on what you're referring to. A relationship that's too personal, not professional, not that's not our jobs. Can you tell us how do we start that? How do we move that on?
So that's the whole aim of community voices. It is about connecting without having a predetermined agenda. It is about articulating what the real issue is and what the challenges are before going on to the solutions. The issue is that you can't use a programmatic approach to connect with communities. You can't use strategies and plans in the way that we define strategies and plans to connect with communities, unless you change the culture. And people are smart. They know if you mean if you're really interested in their lives, or you're just interested in actually getting the feedback so that you can go and tick their box. So unless you're willing and committed and honest about actually why you want to connect with communities and not on your agenda, then all we're doing is actually ticking that box. We can see that tension is emerging now, where we had real support, around community voices, and we still do. But then the tension is going to come. We're going to have to decide. There's the recovery plans now, the ICS developments, the health inequality work streams, and their plans and strategies. And that's where the clash happens, is when you're bringing there's a hierarchy. There's the soft data and the hard data, and almost as if soft data is less and hard data is what you use to validate. The community voices and the work that Meerat did with Sarah and with you, Janet, around actually saying, no, we do have a framework. It is evidence-based, and the stories matter. They tell you what you need to do. They complement the hard data. But they tell you the why. All the other data tell you the where and when and the how, but they don't tell you the why. And that's where you need the stories for change, because they tell you the why.
And over to you, Meerat. What's your feeling on that?
I think Samira said it perfectly. I do think it's about how do we change the narrative so we're not hearing these stories, the same stories again in another 10 years. We've not tackled health inequalities, and we really need to change that now, and it is in the wider commissioning structures. It's in how we deliver health and social care, and it's about seeing communities as deliverers of health and social care, and not just seeing ourselves in the NHS as deliverers of health and social care. So it's about how do we then do that, and who's brave enough in Northwest London, who's brave enough to do that?
And we're seeing in the questions on YouTube is around really moving this agenda around health inequalities and COVID-19 into what actions can the government take, what actions can systems take, what actions can communities take. So I think it's really worth moving our conversation into that space, because we've got lots of evidence, we've talked about the issues haven't changed significantly, they're still there. What do you think the role of national government is on this in terms of Public Health England? You've seen the reports that they have produced recently. A lot of investment's gone into that, right? And what about local governments and the NHS? What should be the role of the NHS? We're talking about resetting the whole button, starting again, moving into the future. This is lovely language, but we need to narrow it down in this talk if we can, right? If there are one or two things that you think that's the message, that is it, that's what we need to do, what would it be for you? And I'm going to go over to Samira and come back to you, Meerat, on that.
So I think we're probably in a unique position. Public Health England report, you know, with Kevin Fenton's recommendations, we have a mandate. We really have a mandate to actually go out and connect with our communities to address the health inequality and the systemic challenges that we haven't had before. I think if we don't use this as an opportunity as communities, as individuals within and beyond our organisational boundaries and geographical boundaries to come together around a shared narrative for change, to push this agenda forward, it will revert. Those ambitions in the public health reports, those plans will revert back to just being plans, and that actually kind of are translated into KPIs, translated into activities with outputs, but no genuine long-standing outcomes.
Okay, thank you for that. And over to you, Meerat. One or two things that you think we definitely have to do if we're going to sort of tackle this agenda.
Invest in communities, not just through money, but through you know, partnering up communities with each other and helping people share skills, but just invest and resource that existing infrastructure.
I just want to put my hands together and cheer our two fantastic presenters today, Samira and Meerat, and also congratulate Imperial College for putting on such a wonderful session today. We've tackled some broad brush issues. We've tried to narrow it down to what actions we can take individually, but what the system needs to take. Seems like a real focus back onto communities. Let's get that relationship right first. Let's build trust relationships before we put out different asks around more information, more evidence, more consultation, more programs. So before we wind up, I just have got a few things to just bring to your attention. There is a survey at the end of this talk on your YouTube channel. Please complete that. We'd like to know how well we've done and whether you've enjoyed the session. And this is part of a series, and we've got another series coming up next week. And I'm told on the 22nd of July, there's a antibody testing session by Professor Christina Atkinson. So please join them. So thank you so much and goodbye. Thank you so much for joining us. We do appreciate it. Thank you for this slide. So it's all there. The question and answers to exploring antibody testing next week, Wednesday, at 5:15 to 6 p.m. And if you want to register, you've got the link there to register ahead of time. It is an open session, so please tweet about it and tell your friends, and let's continue the conversation. But again, I just want to say thank you so much to Imperial College. I want to say thank you to Samira and to Meerat. Have you got a last thing to say about community voices, including our hashtag Community Voices NWL and at Community Voices NWL? But a last comments, Samira and Meerat. Over to you, Samira. Last comments before we wind up.
just say thank you so much for inviting me to this. The key thing for Community Voices is uses social movement principles. So the strength is in its membership. So just join us. It's open to everyone. We really want you to come in and contribute to the conversation.
Thank you, Samira. And over to you, Meerat.
Nothing to add really after Samira. I think she always should have the last word.
Oh, you're so very humble. Thank you, everybody, and have a very good evening. Be safe and take care. Bye-bye.